Hi, I'm Kristen Hayes. I'm a nurse practitioner working at the Margaret West Comprehensive Breast Center. We're a part of the West Cancer Center in Memphis, Tennessee, and I run our high-risk breast clinic. I've been here for about 5 years now. I was a nurse at a pediatric oncology hospital before this, St. Jude, and then I really got interested in adult oncology through my fellowship program. And when I became a nurse practitioner, I joined West Cancer Center, and I kind of joined at the right time when we were starting up this high-risk breast clinic. So it just worked. And I really became passionate about these women who were high risk for breast cancer, but did not yet have a breast cancer. So I see these patients who are at an elevated risk and guide them through their journey of screening, of risk reduction. And I just wanted to share a little bit today about patients I see, what qualifies them to being high risk, and what we have to offer them. And I hope it will be beneficial to each of you if you see some of these patients that qualify or that you think are high risk, and that way you can just have a little more information about this specific patient population and know how to advise patients and steer them in the direction they need to go. So I'm sure most of us have heard this number that 1 in 8 women will be diagnosed with breast cancer. That is about a 12% risk. So every woman, just being a woman walking down the street, no family history, no other risk factors taken into account, a 12% chance of getting a breast cancer. And the latest data I saw said that there will be about 284 diagnoses of new breast cancer in the United States this year alone, and about 44,000 of those patients will die from breast cancer. So this is a real issue, and I really think it's important for us to start hitting this on the front end and not just treating breast cancer better, but being able to identify those that are high risk for breast cancer so we can actually prevent this from occurring and hopefully get these numbers down. And I know most of us probably know someone with breast cancer at least, and a lot of us have someone in our family who's had breast cancer. So, we know these 1 in 8 women, and this affects most of us and a lot of patients we see. So what factors affect breast cancer risk? There's both non-modifiable and modifiable factors. Non-modifiable, of course, we cannot change, but it's important to be aware of what increases someone's risk. So age, of course, the older you are, the greater your risk for getting breast and many other cancers are. Family history is really one of the major risk factors. That's probably the most patients I see are for family history of breast cancer, not just first degree, but first, second, third degree relatives. The more relatives you have with breast cancer, the more your risk increases. And especially if you have family members diagnosed at younger ages, it really drives that risk up. If you have an inherited genetic mutation, that can also increase your risk. So if you've had genetic testing and you have found to be positive for a pathogenic mutation, there's about 12 of them that we know of that increase breast cancer risk. And so having this genetic mutation would qualify someone to be high risk. If you have dense breast tissue, that's identified on a mammogram. And so probably about half of women have dense breast tissue, and that is just how your tissue looks on mammogram. So dense breast tissue shows up as white. Breast cancers show up as white on a mammogram as well. So it can make it harder to decipher if there's something hiding behind that dense breast tissue, harder for the radiologist to read, and easier to miss a breast cancer. There's also been studies lately that have shown just having that dense breast tissue, that increases your risk alone. Being exposed to estrogen, as women, we're all exposed to this. This is not the estrogen you take, but this is just what your ovaries produce. Race, we know African American women have a higher risk of having a more aggressive form of breast cancer, triple negative, and their outcomes usually aren't as great. Ethnicity, Ashkenazi Jewish women have higher risk of having a BRCA1 or BRCA2 genetic mutation, so that comes into play with their risk. If you've had a history of radiation to the chest, so if we see patients who had Hodgkin's lymphoma, for example, as a child, and they had mantle radiation, then their breast cancer risk as an adult is increased due to that radiation exposure when they were younger. If patients have had a previous breast biopsy and the pathology revealed atypical cells or lobular carcinoma in situ, which we kind of refer to as precancerous cells, having that pathology itself increases your risk and makes someone high risk for getting a breast cancer, either in that breast they had the biopsy on or in the opposite breast. And then the age women start their cycle versus the age they go through menopause. So again, this has to do with hormone therapy. The longer you're exposed to hormones, so the earlier you start your cycle and the later you go through menopause, you're exposed to hormone therapy for a longer period of time. And so that increases your risk. Your risk is lowered if you start your cycle at a later age and you go through menopause at an earlier age. And that's why removing someone's ovaries lowers the breast cancer risk since you're removing all that estrogen coming from the ovaries. There are a few things that are modifiable, which is good to know, so we can educate patients on what to do about these. Hormone replacement therapy usage. We understand that some patients need this for quality of life. Really, we encourage women to take a low dose for the shortest amount of time. The studies that we've seen that show an increased breast cancer risk are when patients take this for 3 to 5 or more years. And really, the increased risk comes from taking estrogen and progesterone together. So we encourage a low dose, short amount of time. Obesity, having an overweight BMI or an obesity BMI can increase breast cancer risk. So we talk about lifestyle factors, exercising 3 to 4 times a week, eating healthy. Alcohol consumption, greater than 2 drinks a day for women, or actually greater than 1 drink a day. So 2 drinks a day for women increases your risk of breast cancer. And then smoking increases not just breast, but multiple cancers. We always advise for smoking cessation if patients are able to do that. We've talked about risk factors. What are protective factors? So patients can do things to protect the risk of getting breast cancer. Getting pregnant at an earlier age, something about when you're pregnant and your body's exposure to hormones and how it is responsive to that lowers your breast cancer risk. So if you happen to have a child and deliver a pregnancy before 30, then that lowers your breast cancer risk. There are medications you can take to lower your risk. We'll talk about some of those in a little bit. As we said before, limiting alcohol intake to 1 or less drink a day. Discontinuing hormone replacement therapy if you've been on it for multiple years. Breastfeeding, so each child you breastfeed and the longer you breastfeed lowers your breast cancer risk in turn. Stopping smoking. If your risk is high enough, then you could be a candidate for a prophylactic mastectomy, which is removing both breasts, and that's kind of the most you can do to reduce your risk. And then getting enough sleep. It helps in multiple aspects of your health, and it can also help you in your weight, decrease obesity, which in turn decreases breast cancer risk. This is just a quick slide I like to show. Patients come in all the time asking different things about what diet they should be on, if they should take a certain vitamin, if something has caused their family members breast cancer and what they should do about it. Really, other than what we talk about today, there's not one diet, one pill, something you can take to lower breast cancer risk or something that we know that causes it. Natural deodorants don't really seem to affect whether they get breast cancer or not. Again, there's not a certain diet. There's been some data showing maybe vitamin D levels, if they're low, can increase breast cancer risk. We don't really have enough information on that. There's not any sort of herbal supplements we encourage that really reduce risk or that we see shows a difference in breast cancer risk. And then oral contraceptives. A lot of women are concerned if they have a family history of breast cancer, is it okay for them to take a low dose oral contraceptive for birth control or whatever other reason? And it is. The amount of hormone in a low dose oral contraceptive pill is actually less than your body would produce on its own. So we are okay with women taking that. It does not affect breast cancer risk enough for us to say they cannot take it. So what kind of patients do I see in the high risk clinic? We kind of went over these before. If you've had a previous biopsy showing atypical ductal or atypical lobular hyperplasia, so these are an overgrowth of breast cells either in your lobules or your ducts in your breast, and having this diagnosis, something about those cells being revved up makes them more primed for getting a breast cancer in that breast or the opposite breast in the future. LCIS or lobular carcinoma in situ showing up on a biopsy also increases breast cancer risk. That is not a cancer, it's more of a pre-cancer. Again, if you've had a history of radiation therapy to the chest between around ages 10 to 30, that's when that elevated risk comes up later in life. And then if you tested positive for any one of these genetic mutations, BRCA1, BRCA2, TP53, which is Li-Fraumeni syndrome, PALB2, CDH1, P10, NF1, CHEK2, ATM, STK11, which is Peutz-Jeghers syndrome, or BARD1, we've gotten some new data on. All of these genes, if the patient has a pathogenic mutation in them, then they are at an increased risk for breast cancer. Obviously, family history really is what drives the risk the most. So first, second, third degree relatives, the more relatives, the higher the risk. And the younger patients are diagnosed, the higher the risk is as well, and the higher risk is to have one of those genetic mutations. In Ashkenazi Jewish ancestry, if you are Ashkenazi Jewish, you have one of the above risk factors, you're definitely probably considered high risk, and you have a higher risk of having that BRCA1 and 2 mutation. About 1 in 40 Ashkenazi Jewish women have a BRCA1 or BRCA2 mutation. So it's important to note a patient's ethnicity to see the risk of having that genetic mutation and to see if they need to be tested for it or not. So how do we determine what someone's risk is? We know if a patient has an elevated risk, but we don't know how high their risk is and what we should do based on that number. There are a couple different risk models we can use. The ones I use most in my practice are the Tyrer-Cuzick risk assessment and the Gale risk assessment. Both of these have been validated. They're what NCCN guidelines, the National Comprehensive Cancer Network, identifies as using to show if a patient's high risk or not. The Tyrer-Cuzick has tend to been the most accurate risk assessment, so I probably use that one more. But Gale has been around for a long time, and we use that one also. The Tyrer-Cuzick is more for if you have more than a first-degree relative. It looks at more factors. It looks at breast density. It goes out to second-degree, sometimes third-degree relatives. It looks at genetic testing status. It's just really more comprehensive. And then the Gale looks at first-degree family history only. So if you have more than first degree, you probably want to use the Tyrer-Cuzick. Gale is also better to see a patient who has an atypia diagnosis or has had a previous atypia diagnosis. That risk model is more accurate for showing what someone's risk is. And on either of these risk models, if the risk is greater than 20%, then they are considered high risk. And so I'll just show you the Gale, for instance. Both of these are online, they're free, and so you can use both of them. You just basically fill out information on both of them and enter the info, and it'll show you who is high risk or not and how high the risk is. The Gale and Tyrer-Cuzick both give you a 5-year risk and a lifetime risk of getting breast cancer. And they're online, they're available for anyone to use. It's basically just data entry, putting that information in, and you will see how high someone's risk is. So after you do those risk assessment models, you'll see what the lifetime risk of getting breast cancer is. If that patient's lifetime risk that you've done that risk assessment on is greater than 20%, then they are considered a high risk for developing breast cancer. Remember, an average lifetime risk is 12%. So anyone 20% or greater is where that high risk mark comes into play. Anyone above that 20% mark qualifies for the high risk screening protocol. And so that's where we do a mammogram once a year, like we encourage in every woman 40 and above. We also do a breast MRI once a year as well. And so we think it's important for these high-risk women to not just get the annual mammogram, but to do the every 6-month screening. And that can really help detect things at an earlier stage. So mammogram once a year, MRI once a year, and we alternate those every 6 months. If a patient is unable to have MRI, if they have a pacemaker or if they just can't tolerate it, MRIs can be expensive, so sometimes that can prevent a patient from having it. We do offer bilateral survey ultrasounds to alternate with mammograms, so a patient can come in and have an ultrasound of both breasts, top to bottom, left to right, and it can just look for any changes. It's not as good as an MRI, but it's a backup that we do have available. This high-risk screening, so NCCN guidelines recommend that we start at 10 years younger than the youngest diagnosis of a relative. So if an aunt was diagnosed at 50, the relative would begin screening at 40. If an aunt was diagnosed at 45, the relative would begin screening at 35. We don't do mammograms less than 30. We found that it's really hard to read. The breast tissue is really dense, and it just doesn't add a lot of benefit to mammogram patients before that. And we don't do MRIs less than 25. There are a few genetic mutations that we can begin this screening earlier, such as STK11 and TP53, and that's just because those mutations confer an elevated lifetime risk of breast cancer at earlier ages. Baseline screening, if patients don't want to do this, we always recommend getting an annual 3D mammogram once a year and having an annual clinical breast exam by a provider. The negative to doing these MRIs, I spoke before about the cost, they are pretty expensive. Insurance usually covers it, but they can still be pricey. And there is a higher false positive rate. So about 40% of the time with these MRIs, we'll get a false positive, meaning a patient will come in, will have their MRI done. It shows something, they end up needing a biopsy. It usually ends up being benign. MRIs are good because they're so sensitive. They're not as specific as a mammogram though. So they find a lot of things, but they find too many things. That's why we don't do MRIs on every patient. We think we'd be constantly working up every little thing, but we do think it's worth it in our high-risk patients. We just like to point that out. So if lifetime risk is elevated, that's when we look at, is someone eligible to do the high-risk screening? Now, if their 5-year risk is elevated based on those risk models that we looked at before, then they might be eligible to take medication to lower the risk. An elevated 5-year risk is if someone's 5-year risk is 1.67% or greater. So anyone greater than that is considered a high risk for developing breast cancer in the next 5 years. What can these women take? So if you're premenopausal, you can take tamoxifen. Most of you have probably heard of that. We've given it to women for years with breast cancer to prevent it from coming back. Well, back in 2000, they saw that these women who were taking tamoxifen lowered the risk of getting breast cancer in the other breast. And so they thought, okay, should we try this on patients who've never had a breast cancer? They did. And they were found that patients who never had a breast cancer took this medication for the 5 years that it's been recommended, and it lowered the risk of ever getting a breast cancer, cut it in half almost. So if a patient's lifetime risk is 40%, they take tamoxifen for 5 years, their risk is now 20%, which is just barely high risk. Again, if you're premenopausal, the only medication you qualify for is tamoxifen. If you're postmenopausal, you can take other medications such as Avista or raloxifene or an aromatase inhibitor. Tamoxifen and Avista are the only medications that have been FDA approved for breast cancer risk reduction, but we have done trials on exemestane or anastrozole, and they work similar to how they do in breast cancer patients. They lower the risk of a patient getting it. So those are available as well. Again, these pills are taken daily for 5 years. There are charts available on the NCCN guidelines that shows risk versus benefits to see if a patient, really could use this. Because of course, there's side effects from these medications, and they need to be considered to determine if the patient really could benefit from this or if the risks would just outweigh that. The main side effects from tamoxifen or raloxifene are blood clots. These are selective estrogen receptor modulators, so they're blocking the estrogen receptors in their breast. There's also a small risk of uterine cancer with tamoxifen, and then aromatase inhibitors, a risk of osteoporosis. So you just kind of weigh what the patient's medical history looks like, what's going on, and if it would benefit them to take this medication. Usually patients that I prescribe tamoxifen and raloxifene on do great. Most don't notice they're on it. The ones that do have the annoying side effects that are similar to menopause. So these medications don't put them into menopause, but they have those depleted estrogen side effects like hot flashes, fatigue, weight gain, joint aches and pains are pretty common with the raloxifene. But if a patient can tolerate it, they take it for 5 years. And then after those 5 years, they're no longer considered high risk. And this risk reduction lasts 20 plus years that we've seen. Now, depending on how high a patient's risk is, they might qualify for prophylactic surgery. This is the other form of risk reduction. Prophylactic surgery is removing both breasts, and that decreases a breast cancer risk down to about 1 to 2%. That's the most anyone can do to lower the risk. Of course, not everyone is a candidate for this. So really, this should only be considered in women who have a genetic mutation that confers a high risk for breast cancer. If they have a strong family history, multiple moms, cousin, aunts, multiple relatives on the same side. If they've had prior radiation therapy, that can get the risk up to about 40%. And then just in general, using risk assessment models, if the risk is 35 to 40% based on those models, then that would be a good time to talk about risk reduction surgery if the patient's interested. LCIS, for example, that biopsy that shows precancerous cells, that increases your risk to about 30 to 35%. That can't be included on the risk models, but if you have a patient with that, then they are a candidate to discuss surgery. It's an option. So what happens at these high-risk consults? We see the patients and we do a risk assessment, a Gale or Tyracustic, based on what their risk factors are, and we come up with a percentage, a 5-year risk and a lifetime risk based on those percentages, and we determine what kind of screening or what kind of risk reduction methods are appropriate to the patient. So it's really nice because it develops a personalized plan of care for each patient, and it's tailored to them based on what their risk factors are. And of course, we do follow-up risk assessments every year. I see a patient, I repeat their risk assessment model because age alone is a risk factor. So a change in age increases risk, and family history always changes as well. So it's always important to update patients' family history and see if anything's changed that could increase the risk, and always advise patients about things they can do to lower their risk, those modifiable risk factors we talked about earlier. It is nice in the high-risk clinic, we have access to breast surgeons as well. So if we get some of those false positives from that MRI, they can easily do a biopsy. And there's always access to other multidisciplinaries also. This is just a quick slide about genetic testing. So these are the 12-ish mutations that we know of, the genes that if they have a pathogenic mutation, it increases someone's breast cancer risk. All of these genes increase someone's risk greater than 20% if they have a mutation in them, and so therefore they meet criteria for high-risk screening. We do counseling and testing in the high-risk clinic, and so it's nice to know if patients are positive for this, and it's good to know if patients qualify for this testing. As you can see, all of these would qualify for high-risk screening, especially BRCA 1 and 2. It increases someone's risk up to 60% versus that 12% average risk. So the benefits of being followed in a high-risk clinic, you can see these. Really, the best part of the visit, it's continuity of care. They have access to all different disciplines through the high-risk clinic, whether it be plastic surgery to talk about reconstruction, genetic counselors to do testing, pathologists to look at their biopsy results, radiologists to read their mammograms. And it just creates that tailored care to each patient. I think it's really important that we recognize that all women have a different risk for getting breast cancer. I really think it's helpful to know what someone's personal risk is and to therefore treat them based on that risk and to know what is available.
So really the main goal in all of this is prevention and early detection. And I think it's really important that we're catching these breast cancers early. And so we're preventing the morbidity and the mortality associated with this disease. And then we're even able to prevent some of these with the surgery or with the risk reduction medication. And I just encourage all of you to be aware of this. And when you're seeing patients, be aware of not only the patient's diagnosis, but their family history as well, and think about their family members and if they would benefit from a high-risk consult, and hopefully be able to prevent this disease, get those numbers down that we talked about before, and detect it early, find it at the earliest stage possible, and really help treat this in women and hopefully stop it from ever becoming a problem. Thank you.